Assalamu alaikum. Bismillah ar-Rahman ar-Rahim. Assalamu alaikum. I thank my colleague, Professor Tafazle Haq, and his team to invite me to this meeting. My topic of discussion here would be the treatment of hyperuricemia. Before I proceed further, I would like to share some thoughts about my previous experience. When I joined medicine, which was say about 30 or 35 years back, the concept was that anybody who had arthritis, two tests were done. One was an ASO-T titer, and the other was a uric acid. So if somebody had a raised ASO-T titers, he was diagnosed as suffering from rheumatic fever, and he was put on Panadol. And so likewise, if his uric acids were high, they were diagnosed as suffering from gout, and they were started on the famous allopurinol then. Time moves on, things change. However, in Pakistan, probably this thing has not changed much. And still, I feel that the only thing which has changed in the recent past is the fact that apart from allopurinol, we now also have febuxostat. So the choice is whether to use allopurinol or febuxostat. Now, before I proceed further, basically what I'm going to talk to you about today is, should all hyperuricemia be treated or not? And if yes, then how to treat it and when to treat it. Now, we know that all treatments have possible side effects. And we need to be aware of these side effects. And when I started working on this presentation, I Googled the health line, which is the most commonly health line used by the patients to find what are the possible side effects. And when I Googled around, I found that the side effects of these urate lowering drugs mentioned in there was the allopurinol had significant skin reactions, some multi-organ disorders, and some other problems. I also looked at the side effects of febuxostat, which were probably comparable. And so the new febuxostat did not seem any more favorable than allopurinol, which we were already using. In fact, another study, which sorry, I'll go back to the same slide. Out of these side effects, although they are very rare, but some of these side effects, namely the Stevens-Johnson syndrome, the toxic epidermal necrosis, and the DRESS syndrome, which you see over here, are although rare, but in even the best of centers worldwide, the mortality of these three side effects is close to more than 25%. So that's astonishing, and we need to be aware of it. Another study which recently came out in 2018 by White and et al., where they compared the cardiovascular safety of febuxostat and allopurinol in patients with gout and ischemic heart disease. The surprising thing was that although the side symptoms of both the drugs were comparable, however, the all-cause mortality and the cardiovascular mortality was higher with febuxostat compared to allopurinol. So now with this thing in our retrospective mind, we'll proceed further to the relevant topic, which is hyperuricemia. Hyperuricemia is a common problem, and when we analyze the United States population, it is estimated that 20% of the whole population has hyperuricemia. And in fact, it's progressing. That's because of the population is becoming overweight, obese. There is increased incidence of consumption of sugar sweetened beverages, food rich in purines, and alcohol. And when we look at the prevalence of gout in that population, we find that close to 4% of the population suffers from gout. It doesn't take lots of a big mathematician to find out that if out of these, if there are 5 people with hyperuricemia, only 1 develops gout. So there seems no logical reason to treat all patients with hyperuricemia. So I'm just going to talk about a few slides about hyperuricemia. Hyperuricemia is defined as a plasma uric acid concentration of more than 6.8 milligram percent, although it varies among different age groups in children, male and female, but generally it is said that it's around more than about 6.8 milligram percent. When you look at the etiology of uric acid, which again, I'm not going to go into detail, but obviously it's a common pool, and it all depends on whether uric acid is being under excreted by the kidneys, which is the almost 90% cases, this is the case. But the other can be because of overproduction. And in some individuals that it can be combined of both under excretion and overproduction. These few slides I'm going to just share so that we don't miss important points. We know that lots of reasons for under excretion. The most important is the renal insufficiency and metabolic syndromes, and all of you can go through those in the literature. The most important cause of overproduction is diet and tumor lysis syndrome. Then there are other causes like combined causes where both those aspects are involved, like alcohol, where alcohol produces excess uric acid because of oxidation, and it also affects the kidney in reducing excretion. Fructose foods and drinks are becoming increasing problem because of these fast food industry, which we are now consuming. So how does uric acid affect us? It affects us by two ways. One is by crystallization, and we are very familiar with how uric acid crystallizes, and it can cause various ailments like gout, whether it's an acute gouty arthritis or chronic gout. It can also cause acute uric acid nephropathy, and it can, on chronic long-term basis, it can also affect and cause uric acid nephrolithiasis. And another thing which is becoming more common nowadays and a hot topic is the asymptomatic hyperuricemia, where hyperuricemia affects without causing any apparent crystallization. And it contributes to one of the metabolic syndromes. And there are various studies appearing in the literature nowadays which say that when there is hyperuricemia, there is increased chances of other problems like hypertension. So if somebody has hyperuricemia, the incidence of hypertension rises to about more than 40% in these individuals. Similarly, patients with hyperuricemia, which is asymptomatic hyperuricemia, have increased morbidity. They have a more rapid decline in renal function. They are more likely to develop stroke, and they are also likely to develop osteoarthritis. So now let's concentrate on why does crystallization cause pathogenicity. There is a very good review article by Channon et al. Which looked into how does uric acid cause pathogenicity. And I'm going to share with you this concept which they forwarded. And they say that the most important aspect is you have to have uric acid. So if there is no uric acid, there is no uric acid urate crystals. So the most important aspect is hyperuricemia. Now, it's not only necessary that one should have hyperuricemia to develop crystallization. The uric acid crystals have to become less soluble, and they have to crystallize. And there are many factors which contribute to crystallization or low solubility of uric acid crystals. The most important being high levels of uric acids. Cold temperature causes decreased solubility, and thus it's very common to see patients who have developed gout early in the morning when they wake up in cold weather, when they had their foot pushed out of their under blanket, and they find that they have a gouty attack. Similarly, a pH of between 7 and 9 is also a factor contributing to reduced solubility and increase in certain other anines. Similarly, factors which increase the solubility means that they reduce the crystallization would mean less uric acid level, increased temperature, pH less than 6 or more than 10, and less amount of anines in the body. So whatever the cause, when it does crystallize, sorry, it's probably sound. I needed to continue stop the sound. So whenever there is a reduced solubility, it induces crystallization. The critical point in it is the appearance of the first crystal, which is nucleation. And one crystal begets another crystal. So once a single crystal is formed, which is the critical point, it induces more crystallization. And once these crystallization cascade starts, it affects, sorry, I have to again close this sound. Okay. Okay. When it happens, it induces certain it engages intracellular pathways, namely the NELP3 inflammasome complex. And what it does is it produces interleukin, sorry, it induces the production of interleukins, namely interleukin 1. And we know that now the treatment of canakinumab and rimonabant are basically targeting the interleukin 1. And this is one of the treatment modalities of treating acute gout, which I'm not going to go into detail because that's not the topic of discussion today. And once the interleukin 1 comes into play, it induces crystallization and appearance of acute gout. So just to enumerate the urate lowering therapies, we know that the most commonly used are the xanthine oxidase inhibitors. We also use uricosuric agents like probenecid. The problem with probenecid is that one has to be careful that there are no urate stones in the kidney because it acts by increasing the excretion of uric acid from the kidney. So the most importantly used are these xanthine oxidase inhibitors, the allopurinol and febuxostat. We also use the uricase agents, which is not very commonly used in Pakistan, but it is effective in those who are refractory to the above therapy. Recently, the selective uric acid reabsorption inhibitors, the SURIs, were introduced. But they were soon withdrawn after the phase 4 trial because it turned out that it induces more renal toxicity. So basically, this is now not part of our armaments nowadays. So let's move on to the management of hyperuricemia. I looked around about how to manage symptomatic and both asymptomatic hyperuricemia. My problem for managing symptomatic hyperuricemia was very easy because lots of authorities and the societies have come up with the management of how to treat symptomatic hyperuricemia. Namely, I talked about gout, and the thing which I found more palatable was from the ACR. So when I was looking at how to manage hyperuricemia, this basically quote from Hamlet of Shakespeare's play came into mind. To treat or not to treat is the big question. So this is the same thing, that whether we need to treat patients with hyperuricemia or not. Treating symptomatic hyperuricemia was recently taken up in 2020 by the American College of Rheumatology, and they looked at around 500 RCTs and analyzed the outcome, and they came out with 42 recommendations, including 16 strong recommendations as to how to manage and treat symptomatic hyperuricemia. I have just consolidated the final outcome for your audience, and it says that you need to initiate urate lowering therapy for patients in the following indications. One is that if they have a subcutaneous urate tophi, or if there is radiological evidence of gout, or if the flares are more frequent. More frequent would mean more than 2 per year. Or in the absence of above, one can also consider starting urate lowering therapies after the first flare if the patient has an advanced renal disease, or the serum uric acid is in excess of 9 milligram per deciliters, or the patient also has urolithiasis. So after the first attack, if you have underlying kidney disease, uric acids are high, more than 9, or urolithiasis, you can start urate lowering therapies. And what they also recommend is that the allopurinol is the preferred first-line urate lowering therapy for all patients, including those with moderate to severe kidney disease. Xanthine oxidase inhibitors, how to start them? You start them with a low dose and then gradually increase the dose, and you aim at achieving a level of less than about 6 milligram or preferably 5 milligram per deciliters. And during the first 3 to 6 months, we need to start them on an anti-inflammatory prophylaxis, which may be colchicine, non-steroidal anti-inflammatory drugs, steroids, so that the acute exacerbation is not seen in these patients. Once after 3 to 4 months, when you feel that you have achieved the relevant uric acid levels, which is 6 or 5 milligram per decimeters, you can gradually take them off. The choice of whether using colchicine, non-steroidal anti-inflammatory, or prednisolone will depend upon the patient's condition regarding their indications or contraindications. I also Googled around for various RCTs, which I could find out as to what is the current management plan for asymptomatic hyperuricemia. I came across this article, which is a very good article published recently, and it analyzed about 350 RCTs regarding the management of asymptomatic hyperuricemia. And I again consolidated the same for you to see. All these, this article says is that all these RCTs demonstrate that although there is an increased incidence of gout in asymptomatic hyperuricemia if followed for 3 years, however, there's insufficient evidence to recommend the widespread use of urate lowering drugs in these circumstances. Reason being that they have potential side effects, they are not cost effective, and not all people, as I mentioned, that out of 5, only 1 will develop symptomatic hyperuricemia. Exception to this is in oncological settings where chemotherapy or radiotherapy is induced, and there is a tumor lysis syndrome where the uric acid suddenly rises to very high levels, probably beyond 15 milligrams. In such individuals, you can pre-start them on urate lowering therapy before giving them these chemo or radiation therapies. Regarding the asymptomatic hyperuricemia, what you can do is that if they don't have any symptoms and there's no indication to treat them, what you do is you advise them on lifestyle changes like regular exercise, weight reduction, purine lowering therapies, which includes sugars, starch, fats, with protein supplied by eggs and cheese. They should avoid meat, poultry, seafood, organ meats like जो हम कहते हैं मगज किसी का ना खाओ, गुर्दा ना खाओ, कलेजी ना खाओ, and alcohol. And we should avoid soft drinks and fast food because all these fast food and these beverages contain high fructose corn syrup. These are cheaper as industrial products, and most of these soft drinks and the fast food use these as sweeteners rather than pure sugars. So basically, I'm about to reach the end of my talk. So the take-home message from my perspective is that hyperuricemia, as I mentioned, is a common biological finding. As you see that 20% of US population suffer from that. But asymptomatic hyperuricemia is much more common, and urate lowering therapy is not required in asymptomatic hyperuricemia, except for, as I mentioned, a few instances like tumor lysis syndrome. For asymptomatic hyperuricemia, you need to manage the patient on by lifestyle changes. And when considering use of urate lowering therapy, the benefits have to be compared with the potential side effects. So basically, in the end, I would like to share this saying from the father of medicine, Hippocrates, who said that as to diseases, make it a habit of 2 things: to help or at least do no harm. So basically, this is the end of my topic discussion. If anybody wants to have ask questions, you can ask them according to the protocol of this session, or you can text me on my email, and I'll be happy to answer them. Thank you very much.